Welcome to this 787th CME of Complications for Above India. Today we have Dr. Prashant Saxena with us. He is the Director and Head of Pulmonology and Sleep Medicine and Associate Director of Critical Care at Max Smart Hospital. He is a very experienced interventional pulmonologist and critical care specialist. He received his fellowship training in Westmead and Liverpool Hospitals, Sydney, Australia. He is an MD in tuberculosis and chest diseases. He is a European diploma holder in intensive care medicine. He is a fellow of College of Chest Physicians, USA, a fellow of Indian College of Critical Care Medicine, a European diploma holder in adult respiratory medicine, and he received his interventional pulmonology training in Greece, thoracoscopy training in France, pediatric bronchoscopy training in Italy, and many more which I have not mentioned. During COVID times, he consistently shared his expert knowledge with us through a series of webinars, and that definitely helped us treat our patients better. Besides this, whenever a patient required or a relative required hospitalization in those tough times, he was always there to help us. Today he will be deliberating on recent advances in asthma and a few interesting cases of pneumonia. Please welcome him with a big round of applause.
Good evening, everybody, and I would like to thank you all for sparing your time. And it's indeed a pleasure to be part of the Physician Forum of India. And I have been associated with all of you for almost 5 years now. And post-COVID, this is the second physical CME, but we have done many before COVID in the neighboring restaurant. So we have been discussing a lot of COVID, and I thought today we'll discuss something which is very interesting and important for all of us to understand, and which is a pneumonia. Now, it is very common to have pneumonias in the community. It is very common for all of us to encounter these problems. Anybody can see a patient coughing with fever, cough, and coming to you. And approximately 15 to 30% of ICU pulmonary consultations and 8 to 10% of bronchoscopies are done because of pneumonia. And approximately 20% of presumed non-resolving pneumonia is due to non-infectious causes. So this is very important, that if your pneumonia is not resolving, I have seen people coming to me with 4 weeks of antibiotics or 5 weeks of antibiotics. Then we have to start thinking of a pneumonia which may not be bacterial. The mortality of these pneumonias which are not resolving is very high, close to 80%. So there is a significant chance, if your patient is not improving with a pneumonia, there is a mortality which is very high if you don't diagnose it in time. So what is the resolution of a pneumonia? When do you say the pneumonia is resolving? The criteria is very simple. A patient's heart rate settles, improvement in tachycardia, blood pressure usually happens in 2 days. Fever, respiratory rate and oxygen levels improve usually by 3 to 4 days. And cough and fatigue sometimes may take up to 2 weeks, but by this time the patient usually improves. Radiographic abnormalities, we all know, and I always tell my colleagues not to do a lot of x-rays because it may take up to 4 weeks for a pneumonia to go from an x-ray, despite the patient having improved within 7 days. So don't rely too much on the x-rays. And we have to be clear that certain diseases, comorbidities, can slow the resolution of pneumonia, which is a patient having HIV, diabetes, COPD, more than 50 years of age, Some people have a severe pneumonia to begin with. Infectious agents like mycoplasma, streptococcus pneumonia, bacteremia. Sometimes you can have a resistant or atypical pathogen. And inappropriate antibiotic, one of the very important reasons for non-resolution of pneumonia. If you look at this X-ray, now I will be going into some cases because we always do a lot of theory. Now these are all the cases which I have seen actually and treated. So I thought maybe I will share my experiences with you because I also started treating these patients as a normal pneumonia, but I was surprised when I found out what was the diagnosis. So this was a right upper lobe. You can see there is a cavitary pneumonia which was there, and this patient was not improving, and we had done a bronchoscopy. You can see in the bronchoscopy there is mucosal growth, and at the first instance we thought that this could be a tumor, an endobronchial tumor, but we had done this bronchoscopy and we found that this patient was having pulmonary tuberculosis. So this was a case of endobronchial tuberculosis, and it is not very uncommon. I see a lot of patients with endobronchial tuberculosis. Patient just presenting with cough and fever, and X-ray is also sometimes normal, and then when you go with the bronchoscope, you find evidence of tuberculosis. So it's basically this art of war, and I always believe in this. I think this is a 2,000-year-old book by a Chinese general, and it is known as Sun Tzu. And it's the art of war which has to be there. And when we are treating patients, it's the art of war. And the art is what we have to apply. Now this is a gentleman, this is one of my friend actually. He was 31 years old at that time, and presented to me with acute hypoxia. His saturation was 70% in my OPD. And even my hands were shivering when I was examining him. What has happened to him? And he was talking to me normally. And when I did it, I immediately did an X-ray. You can see there are 5 nodules, bilateral nodules on the X-ray. And when I did a CT scan, I saw bilateral biliary mottling, bilateral nodules. And upon further investigations, I found this gentleman was suffering from hypersensitivity pneumonia. We did a biopsy. The only thing what we did with him was that we took a history. And when I took a history, he said every Saturday I go to farmhouse for a party. And that was the culprit. The farmhouse exposure was causing a hypersensitivity, and this gentleman was having continuous exposure due to that. Now, this is another patient, and I'll give you I'm just telling you the history because I remember these patients. And this was the X-ray on presentation, and you can see this patient is on a ventilator. He was referred to us from a different hospital. That this is a patient who is not getting treated, this is a pneumonia, and I saw a X-ray which is bad, this is bilateral infiltrates. I did the CT scan, I found bilateral pneumonia. You can see there's a bilateral pneumonia in the images. And this is what we did. We did a biopsy. So in our practice, we don't delay too much because we are a referral center. People come here for diagnosis, and we were very early in the diagnosis, and we did a bronchoscopic biopsy. You can see these are branch chain septate. Branch chain septate within the tissue. This is typical of aspergillus. And this patient was having pulmonary aspergillosis and was diagnosed with pulmonary aspergillosis. Now why I wanted to mention this is that nowadays with the increasing use of antibiotics and everybody getting antibiotics from the start, from day one of fever, we are seeing an increasing incidence of fungal infections in the community. Especially in patients who have a chronic lung disease or a structural lung problem. And we must consider fungal infections in our differential diagnosis of a patient with non-resolving pneumonia apart from tuberculosis. So strategy without tactics is the solace route to victory, and tactics without strategy is the noise before defeat. So if you don't strategize yourself, you are sure to get defeated. Always suspect an atypical infection in a patient who is not improving. Don't forget infective endocarditis. Sometimes you can have patients who can have an infection of the valve. I have seen patients who get bloodstream infections and then developing infective endocarditis. So this is a 50-year-old male, high-grade fever, presenting with chest pain on the left, weight loss, non-smoker, takes alcohol, and this gentleman has been on ATT for the last 6 months. This was what we did. This was a CT scan. You can see there is a big cavity, and we thought that this is the MDR tuberculosis. Let us do a bronchoscopy. Some of my colleagues told me send him to a MDR center straight away, but no, I said no, let us just do a bronchoscopy. And we did a bronchoscopic lavage. We found this patient was having staphylococcal pneumonia, and this was a lung abscess which was there. And we treated this gentleman with 4 weeks of antibiotics and was treated. Another patient. Now all these, the good thing about the CT scans is that all these images look the same. Sometimes you are not able to identify what is the causative organism. The radiologist will report to you bilateral consolidation or unilateral consolidation in upper lobe, middle lobe. That's it. They will not tell you what exactly is causing this consolidation. And the moment we see a consolidation, we prescribe antibiotics. This is a gentleman, again, you can see the image, there is a right-sided collection in the chest along with the pneumonia. And we had done a pleural tap in this patient and found this patient was having an empyema. Now empyema is a complication of a pneumonia which is not improving or non-resolving. There is a pleural effusion which gets infected, and unless you drain an empyema, your patient will never improve. You can keep on giving antibiotics for centuries, but this patient will not improve. And we had put in an ICD, and this patient improved after that. So always suspect complication of a pneumonia. If your pneumonia is not improving, you may have a complication of pneumonia. Another person, dry cough for last few months. Now this is the usual presentation. Coughing, few months, antibiotics, I have been taking off and on for 2 months. My X-ray is not improving and I am not improving. This is what the CT scan showed. Now this is a very typical presentation. This is known as crazy paving. And in COVID also now we are seeing this. A lot of patients coming as crazy paving. But this is not a COVID CT. This is much before COVID. Even we didn't know about COVID. And we had done a bronchoscopic lavage. You can see this milky fluid coming out of the lungs. And this is very typical of pulmonary alveolar proteinosis. This is not a rare entity. It used to be rare. But now we know that if you do an early lavage, you can diagnose this condition. So opportunities multiply as they are seized. So you have to grab the opportunity and try to make the maximum out of it. Another patient. Now this CT scan, you can see it shows bilateral ground glassing and small nodules, bilateral miliary nodules. A similar presentation which I showed you earlier. And this patient again, when we did a biopsy, we found this patient was having hypersensitive pneumonia. And let me tell you, Dr. Mangala is here. Good evening, sir. In the last, I think, decade, I have seen a lot of patients coming to me with HSP. Hypersensitive. Somehow the Delhi environment or maybe the NCR, it is posing us to a lot of allergic inflammation in the lungs. Even the patients of asthma, early asthma, young patients coming to us, they have increased a lot in the OPD. So we have to be very careful. Now this is a 56-year-old gentleman with breathing difficulty, headache and ophthalmoplegia. And chest X-ray showing infiltrates, obviously not going. Lab, raised ESR, histophilia, P-ANCA positive. This is what we did in the CT scan. You can see there is a bilateral ground glassing, few infiltrates. And this is what the patient looked like. He had got a rash, maculopapular rash in the palate. You can see the hard palate, the tongue, the legs, extremities. They were rash. And we were wondering about what has happened. Somebody was thinking of some weird pneumonias, other things. A lot of investigations were done, but we did this was a CT scan done. You can see there is a cavity in the lung. So this is a very typical presentation. There was sinusitis and CNK positive. This is a very typical presentation of Sharp-Sauce syndrome, and we diagnosed this patient as Sharp-Sauce syndrome, and the patient eventually got better after the treatment. Now this is another female. This is a female patient, and she actually presented with cough, fever not going, breathing difficulty, saturation dropping, and everybody thought this could be a pneumonia. She was treated with antibiotics. You can see there is a bilateral ground glassing, consolidation, nodular opacities, and bronchocentric nodules. So bronchocentric nodules and perilymphatic nodules are very typical of sarcoidosis. And we had, and you can see a slight hilar prominence also in the CT. There is a hilar lymphadenopathy also. So we had done a EBUS TBNA, and we found granulomas in this lady, and she was diagnosed as sarcoidosis. So a presentation of a pneumonia treated with antibiotics ending up as sarcoidosis. And if we could have been early, we could have saved at least 6 weeks for her, and 6 weeks of cost, antibiotics, and frequent hospitalization. So know yourself and you will win all battles. A patient of chronic kidney disease. Now kidney patients, a lot of kidney patients come to us with pneumonias, and some of them come with hemoptysis and non-resolving pulmonary infiltrates. And this was the patient who came with hemoptysis. My nephrologist thought this is tuberculosis, referred to us. A bronchoscopy has been done earlier, BAL was negative, and this was the CT scan. You can see there's a left lower lobe infiltrate, and we had done this lavage. You can see the lavage is hemorrhagic, increasing redness of the lavage, and this is a hemosiderin-laden macrophage. Hemosiderin-laden macrophage means intraalveolar hemorrhage, and this was the biopsy, and this is a Goodpasture syndrome. So we have to be very careful. A kidney patient, now this was taught to us in MBBS. Kidney patient, hemoptysis, Goodpasture syndrome. But somehow we forget this when we are doing medical practice. So it is very easy to diagnose these conditions. And this was a GPS. This is another patient. You can see there is a big atelectasis collapse on the left side, and we had done a bronchoscopy, biopsy, and turned out to be a bronchoalveolar carcinoma. So a consolidation presenting on a CT scan and turning out to be a case of cancer. So that is why I am discussing this, because it is important not to ignore a non-resolving pneumonia in a clinical practice. So this is one patient, very interesting patient, and you can see there are bilateral diffuse infiltrates across. There is a slight bit of cardiomegaly, fissural thickening, some edema. This patient has had 4 hospitalizations. Treated, discharged. Again admitted after a few days, treated, discharged. We did only one thing, which the previous 4 hospitals had not done. We only did an echo. We found that patient was having a severe mitral regurgitation. This patient was having a pulmonary edema. Every time this patient was getting hospitalized, and every time this patient was getting treated with antibiotics. So a case of pulmonary edema, simple pulmonary edema, and this gentleman underwent a valve surgery and was discharged from the hospital. So this is another patient. Now you can see this is a pacemaker. This is a permanent pacemaker, and you can see these are serial X-rays. I was called to see this as a reference. And you can see the first X-ray, the second X-ray and the third X-ray. There is a gradual worsening over 2 to 4 weeks. And he was getting treated with antibiotics. I just took a history, and this gentleman told me that I am taking a drug which is known as amiodarone. And my head just stuck on amiodarone. I didn't do anything else. I just took the history again and I confirmed. And CT scan also, you can see the previous CT scan and the last CT scan worsening. We just did one thing, we stopped amiodarone. It was a reversible illness and this gentleman improved. Now, this is something which is usually seen. Now again, a pneumonia, you can see there is a air bronchogram, there is a dense consolidation, and you can see there is something here, there is a filling defect. So this was a CT, contrast CT, and this is a pulmonary embolism causing a wedge-shaped consolidation in the lung. And initially he was getting a CT scan which was a non-contrast CT. Nobody thought of a pulmonary embolism. We did a contrast CT scan. We found the patient was having pulmonary embolism. We stopped all the antibiotics. We started anticoagulation. The patient improved. So it is just thinking about what is out of the box. So making no mistakes is what established the certainty of victory, for it means conquering an enemy that is already defeated. So don't forget the non-infectious causes, and this is just a chart to demonstrate how we proceed. We take the history, we examine the patient, we take the drug history, the exposure history, travel history, all these things have to be taken, and then once we feel that patient needs an invasive test, a bronchoscopy or a biopsy, then we don't shy away, we just do it. So please remember that antibiotics have to be evaluated, because sometimes the patient may not have got appropriate antibiotics according to culture sensitivity, appropriate dose, and all these things have to be remembered. And gram staining of sputum, I don't believe in the gram stain much, because sputum is most of the time contaminated, especially after the antibiotics. There is always a contamination and something else grows. Don't delay CT thorax. Sometimes we see X-rays, but please, if your patient is not improving, just have a look at his lungs. And early bronchoscopic evaluation is mandated in a patient who is not improving in a pneumonia. So, this is what the history of Coca-Cola is, and this is how we have emerged. We have tried to introduce newer technologies, compact models, and this is what I propose, that we have to be living up with the present scenario and try to incorporate the advances which we have seen. So, this is what is my mantra of life. Listen to everyone, but don't always be a consensus man. Get used to being alone in decisions.
Very good.
I think I will.
Yogesh.
So you have one more cup?
I think I will wind up.
इधर बैठ ऑल
So those were
बैठ जा
So those were really wonderful cases that Dr. Prashant Saxena showed us, and the moral of today's talk is, if a pneumonia is not improving, please look for other things. It could be anything but pneumonia. And lung disorders, not only lung disorders, vascular disorders like embolism, cardiac issues, they all can cause pneumonia. Even foreign bodies can look like pneumonia sometimes. So, the house is open for questions. Mike Giravan.
As usual, question.
What a nice talk, Prashant. So those were really wonderful cases to learn. Non-calcular carcinoma, tuberculosis, pulmonary embolism, and you talked about the IIT as well because of Amiodarone. We lost one of our great cardiologist friend because of Amiodarone. He had ILD and progressive ILD, and finally we lost him due to respiratory failure. Now, little word about the newer guidelines like molecular diagnostic testing as compared to the old or conventional diagnostic testing. We need to probably increase radiological diagnosis to the tune of 66% achieved with molecular testings. I'm talking about the PCRs, which would identify or diagnose bacterial or viral or atypical bacteria. So are we doing this now? Because the results are available in 6 hours time to the molecular testing.
Yeah, very well. So, a valid point, sir. And nowadays we have respiratory panel, which is the name of the test, and it's a PCR based test.
Right.
And it can detect up to 26 antigens, including virus, fungi, bacteria. And in our setup, the report is available in 2 hours. So, but important thing to remember is that this is a test which has to be reserved. It is not a test which has to be ordered for every patient. It is a patient like this patient, which is non-resolving. Then I would, because it's a 18,000 blood test, because it is giving you 25 antigens.
Worth it? Yeah.
Yeah, but worth it.
Especially in patients who are already on antibiotic therapy, this seems to be the best test to do. Okay, tell us, Dr. Prashant, a little about the newer guidelines about COPD. See, recent research suggests that elevated levels of microRNA 21 is responsible for most of the symptoms of COPD. So the use of microRNA 21 inhibitors like entacomib 21 probably seems to be changing the scenario and the understanding of the COPD. Sir, a word of that. This was published just recently last month.
We are also aware of this, and molecular tests and molecular drugs, the biologicals and all these drugs are coming up, not only in COPD but in asthma also. And microRNA based technology is an emerging technology, as you must have read in the article also. This is a drug which is still under a trial, and they are investigating it about the effectiveness. The problem with COPD, if you ask me, the problem with COPD is that it is an irreversible disease. The goal of COPD treatment is relief of dyspnea, prevention of exacerbation, and giving a good quality of life. This is the goal of treatment of COPD. And if you look at the goal, I think the present armamentarium is good enough to justify it. But if somebody is spending more, because these are very expensive molecules, like if I talk about umalizumab and mepolizumab in asthma, these are the drugs which are so expensive. Even if I am using and the patient is getting better, after 2 or 3 months, they will stop it ultimately because it is not covered by insurance. So if this drug comes, and I have always asked my pharmaceutical company colleagues that please reduce the cost of the medicines, because expensive medicines a patient may take 1 or 2 doses but not for a year.
Prashant, why I said that was because this completely changes our understanding of the COPD. See, absolutely a new understanding that we never.
We'll have to wait for the final result.
Right, sir. So, little word on the high versus low corticosteroids in COVID-19 related organizing pneumonia. Data suggests and support that the low dose corticosteroids probably are better options.
Yeah, so very good point. I think this was what we did in the second wave, the Delta mania, I would call it, and a lot of steroids being prescribed right, left, center. And then the study came where they showed us that 6 milligram of dexamethasone and equivalent for 10 days is good enough. Don't go beyond it. And it has to be given in a patient who is hypoxic.
Right.
With a pulmonary infiltrate, not in any other patient. So you are right, low dose is what we are doing, high dose is out of the question.
Right. So my last two questions, Dr. Prashant. Lancet Respiratory Medicine this month, June 2022, talked about the update on the STOIC study, which showed that a distinct nasal inflammatory response during the early phase of COVID infection may be altered by early administration of inhaled budesonide.
So this is the observation which has come up now, but we are using inhaled budesonide since the first epidemic, because the earlier studies which came, including the AIMS study, and AIMS was the first institute which actually prescribed inhaler. It was not even in the guidelines. So we are using inhaled budesonide in these patients, and I am using nebulized form.
Right. So what does it do? It probably prevents viral replication. It reduces inflammatory markers as well. But the principal trial said that statistically not significant, but they did say it reduces the duration of the illness and reduces mortality as well. And the NICE guidelines haven't endorsed this.
The majority of the trials have failed because we get the results from various centers which have got different equipment, different manpower, different doctors. So there are a lot of biases. That's why I would just say one thing, that we use plasma therapy, we use IVIG with a lot of benefit in 3 or 4 centers in India, but not in other centers. So this is a very different approach. I mean, it's very difficult to comment on studies which are not randomized.
Okay, Dr. Alma says keep it near the mouth.
Yeah.
Okay.
Not in the.
So, my last question, Dr. Prashant. Awake pronation may not be beneficial in COVID-19 related acute hypoxemic respiratory failure. 2 recent trials have said that there is no difference in intubation rates, no difference in length of stay or mortality or hospitalization. Are you still suggesting awake pronation, sir?
Yes. So the problem with COVID and the subsequent inflammation is that it is basal. There is an involvement of the bases. The bases have to be opened up. There is only one way how you can open the bases. Either you apply a pressure, a CPAP, or you ask the patient to lie flat on the tummy. There is only 2 ways. And I would do it.
We understand that, but the recent 2 trials said there is no much benefits.
Yeah, because they did not consider the other therapies the patient was on. Was the patient not on other therapies? Only if you are comparing proning with no proning, then what about the other treatments which were going on in this patient?
I would believe you. Thank you, sir.
Thank you, Dr. Tulsi. Just one question, Dr. Prashant. You showed us 2 cases of hypersensitivity pneumonitis on CT scan. What is the usual presentation? And how a clinician will suspect hypersensitivity pneumonitis before doing CT scan?
Usually they present like an asthmatic. They may be having shortness of breath, progressive, and then cough. Usually these patients are slightly hypoxic as compared to asthmatics are never hypoxic. But in HSP, there is a lot of inflammation in the lungs, so the saturation tends to fluctuate. And they are very distressed. You will see a patient who is looking very comfortable, but if you look at the saturation, if you examine the patient is very bad. So there is a slight difference in the presentation of these 2. And when you take the history of exposures and other things, pigeon exposures, living in a moist environment, all these things will be positive. That you have to see. So history is very important.
Dr. Prashant. Hello.
Hello. Dr. Prashant, thank you. So nice. You are a gem. You are an authority in pulmonary diseases. I am Dr. Vinod and I am treating sexual medicine and HIV. Basically, sometimes patients come to us. If a patient is HIV positive, he is having some fever and the CD4 is normal and he is having some unpathological fever. Usually when they go to any doctor, they put him on Ceptron DS and all these medicines. My question is, sir, if a patient is having CD4 count, which is normal, I repeat, which is normal, that is above 500, and if he is having an unpathological fever, why the pulmonologists or the doctors are putting the patient on ceftriaxone? Because if the patient is having CD4 count less than 200, I can understand the patient is having HIV or HIV/AIDS, and if the CD4 is less than 50 or 40, then definitely the patient is to be put on the secondary medicines. My question is, why, if the patient is having more than 500 CD count, they are putting the patient on ceftriaxone? Why?
So, I mean, answer for me is simple because I don't put these patients on ceftriaxone. Number one. Number two, fever in HIV is not a cure. I mean, it is an evaluation. Complete evaluation, whether it's a disease, whether it's an infection, or whether it's a response to the medicines. Sometimes with the medicines also fever comes. So patient has to be evaluated on these three lines. And I would, for a pulmonologist, I would do a scan. I would not shy away. If my scan is okay, I will not give the patient anything. And the CD4 count, obviously, we have to correlate. Even if the CD4 count is low, I have to see whether I have to give prophylaxis or not based on the HIV viral RNA load and the CD4 count. And you are right, if the CD4 count is low, then we have to consider prophylaxis because it's a guideline and we have to follow it. But not for normal counts, I don't give. I will never.
Another question, sir. See, if a patient is having CD4 high, why the patient is not considered for what test you will recommend? Because there is a TB gold test available right now. Earlier we were doing ELISA test for TB, but now it has been discontinued. Unfortunately, I say because it was a very nice test.
Now,
TB ELISA test.
unfortunately, it has been discontinued. But
if a patient is having, for example, CD4 count more than 500, then definitely the patient should not be put directly on the, what do you call it?
Prophylaxis for
tuberculosis.
We don't do it.
But what is the test? What is the gold standard test you are recommending?
We do the interferon gamma assay.
It is a TB gold, yes. Yeah.
Interferon gamma assay is the recommended test. And if the interferon gamma is positive, then you look at the CD4 counts. And the patient falls into the category of prophylaxis has to be given because the patient can have a tuberculosis.
Will you start all the medicines for tuberculosis or only prophylaxis?
No, only prophylaxis. INH and rifampicin for 6 months or INH alone for 9 months.
Now it is rifampicin, not even rifap.
Yeah, but rifampicin is not here.
Give it to Smalley.
Smalley.
It is very difficult to get.
Sir, I would like to have a comment from Dr. P.K. Manglas.
Yeah, he is the authority.
No, very well spoken. I think non-resolving pneumonias is a very important topic, and in spite of attending all these talks, you see, even then every patient is a challenge. It seems simple once the cases are worked out. Some will turn out to be TB, some will turn out to be vasculitis. Fungal infections usually do not happen unless the patient is immunocompromised. A lot of antibiotics.
इसको ऑन करके ऑफ कर दो सर, ऑन करके ऑफ कर दो।
माइक चल रही है
उनके पास करो ना। विजय,
अरे बेटा तेरी बैटरी खत्म है।
You see, like you should be very careful. Case of fever, and you see a cavitating lesion, and the sputum is negative. Rather than putting them on empiric ATT, I think you should investigate them for something like vaginal. We've had such cases. Like recently, we had a case presented with fever. Lawyer presenting with fever for 1 month, and the diagnosis came out to pulmonary embolism. You see, we did the CT chest, CT abdomen, and we found there was a pulmonary embolism. She had COVID in February. Probably we thought that could be the reason. But then we did investigate for hypercoagulability. Somebody having you see shadows in the lungs and there is no fever and it is not responding, always keep the malignancy in mind, like bronchoalveolar CA, and threshold of doing bronchoscopy and biopsy should be very low. You see, you should aim for doing a definitive diagnosis. Like all the cases Dr. Prashant Saxena did early bronchoscopies, do a BAL, take a biopsy. Hypersensitivity pneumonitis is really the most common interstitial lung disease in our country, and you see, it is a very serious thing. It is rarely you see the pigeons or you see some hay exposure. Most of the time, you are not able to pinpoint. And you give them steroids, you are really rewarded because patients come and they are doing very well. And most of these patients will come, and even if they have a normal saturation, you just make them walk and they'll desaturate to 70%, 80%. And you do a CT scan, you see a lot of GGOs and nodules, as Dr. Saxena, you see, showed. So these are certain things that your threshold should be high, and you must do a TBLB. Wherever indicated, you should take a biopsy. Like we had you see, GM from UP who was an engineer, and this guy was presenting like asthma. We treated him with the best treatment of asthma, but next time the response was not all right. We did a CT and we had a thymoma line there. So you see, your index of suspicion should be high and be invasive wherever required. Don't hesitate. Don't give diagnosis to yourself. It is patient's life. Explain to him well and do the investigation. Whether it needs open lung biopsy, transbronchial lung biopsy, cryo biopsy, I think your threshold should be high. Recently, you see, 4 young lady of 37 years was admitted with us with history of fever, cough, and when we took the X-ray, she had a cavitating pneumonia on the left upper lobe, and she was producing lot of sputum. The AFPs were negative. We told her, we'll do a bronchoscopy. नहीं डॉक्टर साहब अभी बाद में कर लेंगे. हमने कहा नहीं, ये करना तो है ही. Then she says कि अभी कर लो. We found that the left upper lobe pus was coming out. When we cleared the pus, there was a mass lesion there. And when we did the biopsy, it was not malignancy. It was reported as pseudotumor, very low-grade lymphoma. And we sent to Dr. Vora, and malignancy was ruled out. We sent it to the surgeon, and this lady is going to have a pneumonectomy. So she is not able to take up. But if we had not done a bronchoscopy, we'll be missing a diagnosis. Always think that if a patient is coming to you, if you are the last person, don't think मेरे से नहीं हुआ तो कोई और करेगा. You please do it. Take it as a challenge. If you can't do it, refer to a person who can do it. Thank you.
And I will take just a few minutes. I will ask some questions and just one comment as far as Dr. Mangla is concerned. I practiced in Nizamuddin sir for 25 years, 25 long years.
Why don't you come there? We can see you.
I am still on the camera.
Camera will come.
So,
Camera will follow you here.
I practiced in Nizamuddin for 25 long years, and I got a patient from Nizamuddin whose son, who used to get breathless after he used to play football, and they were thinking that he has some cardiac issue, and when he came to me, I checked him up and I said, I don't know, doesn't look any cardiac issue, but he says, no, डॉक्टर साहब जैसे ये घर पे आता है, ये एकदम से breathless हो जाता है. मुझे समझ में नहीं आया मेरे को. So I got all his investigations done, very wealthy family from Nizamuddin, and this young boy of 18, 19 years old, he told me, डॉक्टर साहब मैं घर पे आता हूँ तो मैं एकदम से मुझे सांस ऐसा फूलता है. मैंने कहा कोई होमवर्क का प्रेशर है, कोई और प्रेशर है, कोई गर्लफ्रेंड का इशू है. नहीं ऐसा कुछ भी नहीं है डॉक्टर साहब, मेरे को बस एकदम से सांस फूलना शुरू हो जाता है. एनीवे, मैंने कुछ समझ में नहीं आया, मैंने जितनी भी अपना तरकीबें थी सारी लगाई. अल्टीमेटली आई स्पोक टू डॉक्टर मंगला एंड ही सेड ऐसा करो उसको मेरे पास भेज दो. तो आई सेंट दिस बॉय टू डॉक्टर मंगला एंड डॉक्टर मंगला sorted it out in 1 minute and he gave him a course of steroids, and this boy came to me very very happy, and his father told me, sir उन्होंने तो सवाल ही एक ही पूछा. मैंने कहा क्या पूछा? बोला घर में कबूतर तो नहीं है. So I I called up Dr. Mangla sir and I asked him, sir, कहता भाई ये सोचिए फुटबॉल खेलता है 2 घंटे कुछ नहीं होता है इसको, और ये लड़का घर में आता है, कहता है इसको अगर साइकेट्रिक इशू है तो फुटबॉल खेलते हुए क्यों नहीं होता, वो ये घर में आता है, घर में आते ही इसका सांस फूलना शुरू हो जाता है, हर रोज होता है, so there is something happening. So it's कहता there are hundreds of pigeons in the house.
This so is a different Dr. Chauhan to what Yuvraj Singh had. You see?
He had a different thing, sir.
Yes, but he was also coughing and he was breathless and he was then diagnosed with some...
With tumor?
Yeah.
With tumor.
So this is different to what case you...
With the germ cell tumor. This was very specific. He used to play football, come home, and the moment he used to come home, he used to get breathless. Anyway, great sir, Dr. Mangla sir.
So did Dr. Mangla put him on ICS or systemic
Dr. Mangla
steroids?
put him just on simple, he is a great...
ICS or systemic steroids?
He put him on oral steroids.
Very good.
Oral steroids.
What about ICS?
I don't know about ICS. He just put him on oral steroids. The boy was fine.
Dr. Mangla?
Corticosteroids have hardly any role in HSP, and I would just like to comment hypersensitivity pneumonitis. It is a very dangerous illness. You see, even if you ask them to stop exposure, the antigen remains in the ear for a year or so. If you are not managing it, these patients will go on to total fibrosis and they will require a lung transplant. So never take it lightly. Then the patient, ghar badal do, lung dobara nahi milega. And be very clear about it. Be very clear about it. We have had n number of patients with here, 37, 40-year female, landing up, can't walk.
Any role of Montelukast also here?
Pardon?
Any role of Montelukast here?
No role.
No role.
Role is avoid exposure. That's it.
Sir, wonderful talk, Dr. Saxena sir. Just a minute, sir, I am in the midst of asking questions. You are a great, you believe in great medical ethics, sir. You can't suppress my voice of freedom, sir. Like sir, please.
I also play.
Sir, and I do not belong to any party, sir. I belong to your party. I have 46 MLAs, sir. Please. I will change the government. You are Dr. HP Singh is always my brother, and whenever I call him, he is always elder brother. Sir, your question still remains. Sir, I will ask some pertinent questions. Sir, great presentation, and you are great COVID teacher during COVID times. Sir, you taught us about GGO, bilateral ground glass opacities, and we talked about antifibrotic therapy in one of your sessions, in one of the webinars, again moderated by Dr. Vaisapal sir. Sir, all those patients who had bilateral GGOs, what is their follow-up and what are we doing with them? Are they having deranged pulmonary function test? Are they still on steroids? Are they on antifibrotics? Are these people candidates for long-term complications?
So actually this is a book question. So bilateral GGO, it is a presentation which comes on CT. A ground glass appearance, which is a bilateral GGO. Now, bilateral GGOs, if you classify, they can be infective, they can be non-infective, or they can be an early marker of interstitial lung disease. Right? Usually in these patients, you have to start from obviously the history taking examination, and like I showed you, a spectrum of cases. Most of these patients had bilateral GGOs to begin with. So it could be anything. GGOs is not specific for any disease. It is a ground glass inflammation which is coming up in a lung. And you have to find out what is causing the ground glass inflammation. So it's an evaluation which includes all the, excluding the infections, non-infectious causes, the exposures to pigeons, haze, any other foreign body exposures. I have seen patients, these guys, young boys, going to clubs and next day coming up with breathing difficulty. फिर पता लगता है रात को हुक्का पिया था, बताते नहीं हैं. I had one patient, I still remember, and this patient I got a call at 11 p.m. in the night कि ये बच्चा है, छाती में दर्द हो रहा है. He was a 17-year-old guy and मेरे से भी ज़्यादा heavy था, लंबा, and उसको लेके आए. तो उसके मम्मी पापा obviously they were concerned, and I had evaluated him. मेरे को भी कुछ समझ में नहीं आया. मैंने CT scan कराया. CT scan में there was something there in the lung, right side में. अब हमें नहीं मालूम. और बच्चा बोला कि मैं तो बर्गर खा रहा था और then suddenly I had pain. फिर मैं कोने में इसको बात करी, इसको समझा. तो that guy वो जब हुक्का पी रहा था तो उसकी जो फनल होती है वो अंदर चली गई, निकल गई, and that had got stuck up in the lung, and I think it took us 3 hours. We fully sedated him. He was under GA. We took a foreign body process. उसको निकालना, क्योंकि our pipes are also funnel shaped, so that funnel fitted up with the pipe. उसको निकालना possible नहीं था. 3 hours के बाद निकाल दी. अगर नहीं निकालते तो उसकी 1 लाख तो कटता ही कटता, ऑपरेशन भी होता. उसके बाद से कसम खा के गया था आज के लोग का नहीं, मैंने किसी और को भी वक्त नहीं देना. So this is what the history, I mean the magic of history is. You have to take the patient into confidence and take the history.
Dr. Chauhan's question,
Sir,
you didn't answer.
My specific question is
Yeah.
regarding all those COVID cases on which you had a wonderful talk on antifibrotic, who had the entire lung becoming white and fortunate to survive. What about their prognosis?
Yeah, so I mean I think we had this talk in the Hilton where I showed that early antifibrotic therapy.
Yes, sir.
Along with steroids.
I want to know your experience now in real time.
I'm telling you what I practice. So a patient coming up with pulmonary infiltrates, this is about COVID. A patient whose saturation is fluctuating, hypoxic, we usually start with patients on steroids, which is the low dose steroids, and we follow these patients up. Some 95% of the patient will improve.
On their own or with steroids?
With steroids,
With steroids. Starting.
1 to 2 weeks, finish.
1 to 2 weeks.
Finish.
Okay.
You, no. Don't you start antifibrotics?
Sir, 95% improve. But there is a subset of patients, and there is a criteria. These are the patients who have very, very high inflammatory markers like IL-6, CRP, ESR, who have a presentation which is improving. We repeat CT scan, we rule out other complications. Sometimes patients develop pulmonary embolism, sometimes patients develop pneumomediastinum. These are ruled out, and I personally start after the first week early antifibrotics for this category of patient who persist to have infiltrates, who persist to be on oxygen, who persist to be clinically not well.
And how do you long continue with antifibrotics?
Antifibrotics has got no, there's no guideline even in ILD how long to continue with antibiotics. We don't know. But if it is started, I believe at least 3 to 6 months. And like I showed in my last lecture, we had continued for 3 months, almost complete resolution of the pulmonary infiltrates in one patient, and up to 4 to 6 months. I have seen only 2 or 3 of my patients who were at the end of a year on antibiotics. Rest, most of the patients of COVID had improved. This is
Sir,
COVID ILD.
What is your preferred antifibrotic? Sulfonidine or Nintedanib?
So Perfinax and Nintedanib, the biggest problem with Perfinax is that you have to take 5 tablets 4 to 5 times a day, which is very difficult. And the extreme nausea and vomiting is a side effect. That is very limiting. And most of the patients say, "Apni kha sakte ye 5 goli."
LFT is deranged.
LFT is common for both.
Can I add? So Dr. John and Dr. Prashant, probably GGOs are not as progressive as ILDs. They resolve in about, as you said, 6 to 12 months. ILD is progressive. Thank you, sir.
You comment, sir?
So Nintedanib, I will speak complete this. So we prefer Nintedanib because easy dosing is there. You give 1 capsule in the morning, 1 capsule in the evening, and just look at the liver function test. Tolerability is also better. Some people complain of diarrhea, and then that can be taken care of. Usually they improve after a few days. You have to just counsel them. So my preference is the drug which is just 1 capsule in the morning instead of 5 4 times a day. That is.
Sir, my last question, but very dear to my heart. We are having a wave of COVID again in Delhi. And many of these people are those people who had COVID, Delta, the most threatening, life-threatening complication. And these people are panicking absolutely, you know, and they are saying, Doctor Sahab, ऐसा करो वो package दे दो जो आपने दिया था और दोबारा से वो शुरू कर दो सब कुछ. So what is now happening with this Omicron variant with people who had Delta infection last year during this time when we had just a nightmarish time, all of us?
So, abhi tak, the patients which we have seen, the epidemic which happened just before this one, was purely a Omicron.
We are now in the grip of another epidemic, another wave.
That's what I am coming to. So, अभी जो पिछले 4-5 महीने पहले हुआ था उसमें कुछ हुआ नहीं.
जी sir.
अभी जो चल रहा है, the patients which we are seeing in our ICU also, we are seeing some patients who have become very sick. They have been on a NIV, they have been on a ventilator also. One of my patients is on a ventilator, and one of the patients who has come out of the ICU still on the high flow nasal cannula, developed IND, and this is the patient of this epidemic. So don't consider all the cases to be Omicron. You can still have a Delta variant within the community.
But Dr. Prashant, these cases, probably the B3 or B4 you are talking about, aren't involving the lungs as much as the Delta involved.
I just told you I have got 2 patients.
Maybe, but not as much as the Delta variant.
These are out of 5 patients.
Sir,
I'm telling you what I am saying.
Sir, for the benefit of everyone.
I was very happy with the last epidemic. कुछ नहीं हुआ था. अभी we have to decide. We have to tell them early warning signs. You cannot tell them कि ये Omicron है 2 दिन में ठीक हो जाएगा. ऐसा बोलना नहीं चाहिए.
So were these patients high-risk patients, elderly patients, vaccinated, unvaccinated?
All vaccinated तो सारे हैं. Booster वाले भी हैं. Almost everybody has a booster.
So no role of Paxlovid here?
Paxlovid we are not using.
Not using.
Sir, for the benefit of everyone, because we are all seeing COVID cases and all very senior physicians, what we practice during the Delta wave? Azithromycin, doxycycline, ivermectin, steroids, and the gold standard anticoagulants, the normal agents. What is holding true for this epidemic? What should be, which is the antibiotic of choice, and should we put all of them on anticoagulants, especially the elderly population?
So, with the learning of the last 2 years and the studies published, I think SCQS, ivermectin is out.
Completely out. No route.
Favipiravir is out in the guidelines. So Feviflu is out.
Molnupiravir? What about Molnupiravir? वो खत्म कर दिया था.
आपने सारा नाम नहीं बताया.
खत्म कर दिया.
So azithromycin stays, doxycycline stays.
The dose of azithromycin?
We are using BD doses.
BD. How many days?
3 days.
Only 3 days.
That's it.
500 BD for 3 days.
And doxycycline 100 BD for 5 days.
We are still using?
This is for patients who have fever, sore throat, and a lot of upper respiratory symptoms.
Both.
Not for everyone.
Both azithromycin as well as?
No, one.
Only one. Either or?
Either.
Okay.
And no antibiotic for anybody else. No antibiotic.
What about these Montelukast, Ensopharidine?
Yeah, so patients sometimes they are having a lot of nasal problems, sinus issues, sore throat. See, these all symptoms are there, we give them antiallergics. There is no point just to trouble them further.
Sir, a lot of these patients are coughing. And I spoke to Dr. Mangla sir.
CT or
and and I told him, sir, one of my patients I am nebulizing. He said, don't nebulize. There will be so many, if you nebulize, then you are sending everything into the air and the whole family will get infected. Sir, what is your advice about nebulizing these patients?
Sir, if a patient is at home, and I believe everybody will be having COVID, number one. And if the patient is isolated, then I don't fear nebulization. So I am an early starter of inhaled corticosteroids.
Your preferred one?
Budesonide.
Budesonide.
This is what I said. This seems to work, right? And started right from the first day.
Right. How many times?
Inhale budesonide 800 micrograms twice a day.
This is puffs.
This is the thing to give.
All right.
What about oral steroids?
What
Oral
else?
steroids sir, मैंने आपको बताया था कि only reserve, see, all the guidelines
Late
across
phase.
the world, including our experience, is reserved for hypoxic patients.
Only for hypoxic.
Late phase inflammation. Late phase
Sir, hypoxic patient.
Right.
My patient comes to me on day 192 saturation, I will use steroid.
Right.
CT बाद में करूँगा मैं.
Sir,
Steroid.
the Omicron wave and the subsequent waves, including this wave, we are not getting as much lung involvement.
अभी तक नहीं है sir.
In fact, very rare involvement.
मैंने
Sir,
आपको
what is the indication for doing a HRCT test?
any patient whose saturations are fluctuating and is having serious symptoms, we should do CT.
We should do a CT.
When it cough is serious, steroids should be started or
If his cough is bad,
इसका steroid दीजिए sir, puff दीजिए.
बताया ना budesonide 800 BD से बताया ना डॉक्टर तुलसी ने.
Nebulizer दे तो puff नहीं ले पा रहा हूँ. Nebulizer 0.5 milligram per saturation.
Right. Yeah, Jitendra, come here. We want you to catch on the camera. Yeah, and you'll be on YouTube.
Okay.
Give whatever money you want to the forum. Please come here. Ask the question.
So what is the role of glycopyrronium? So glycopyrronium is a long-acting screening antagonist, and it is used for patients who have COPD.
Yeah.
We are not using it in patients who have Omicron or COVID, unless they have a background of COPD.
So what about monoclonal antibody?
Glycopyrronium is talk hai. Next talk sir.
So, sir, Dr. Saxena, sir. Doctor,
It is very effective molecule for
Dr. Jitendra Saxena has asked a very specific question. If you have a patient of COPD who has got COVID, then glycopyrronium is a good choice?
Not alone.
Not alone.
We use with combination. See, it is a long-acting muscarinic antagonist, LAMA. You have to combine COPD therapy. Either a long-acting beta-2 agonist with the LAMA, or inhaled corticosteroid and your LAMA.
But this has been used recently for
both.
although the anesthetists have been using it
Only.
for increased secretions. Why is the
Because glycopyrronium is a long-acting single dose molecule with less side effects.
everyone will keep quiet. Dr. HP Singh will ask a question.
सर इधर आ जाओ कैमरे के आगे
मैंने अनाउंस कर दिया था.
इधर आ जाओ इधर कैमरे के
इधर आओ ना सर, कैमरे पे आओ ना.
चलो बटन दब गया.
अरे सर हमारे बॉस हो सर मेरी नौकरी लगवा दो सीधे.
एक लेटर हमें भैया जरा भी दे दे. ये मेरी अथॉरिटी है, still I can do it.
I love Dr. HP Singh,
Sir,
my elder brother.
my simple question. One of my friend, he was having H1N1 in 2019. Again in 2021 he had twice COVID. Again in May 4th had COVID. All 3 times he had a breathlessness, fever, cough, malaise, everything. And he was treated and advised steroid. All right. Again in the second phase, steroid, all right. Third phase also in May, steroid, all right. Still today he taking steroid, pretty good. So just I want to know, this problem is due to H1N1 or COVID? That's my question.
See, both of these are viruses.
Yes.
And most viral infections causing reactive lung disease or airway disease is not uncommon. And this is what happening in COVID also, H1N1 also. Previously in H1N1 also we have seen a lot of patients who take hone ke baad we have to give them inhaled steroids for a longer time. Some people even develop COPD after the viral infection, they don't improve. So this has to be followed up. That's why the importance of symptoms like breathlessness and cough post-COVID is very important, because you have to follow up these patients for at least 3 months. first 3 months. If they don't improve, you have to do CT scan, pulmonary function test, echo, and again they treat accordingly. So you are right, your observation is correct that some of the viral infections can have a resultant reactive airway inflammation or COPD, or some patient asthma also.
सर अब क्या करना चाहिए?
उनको सर